Welcome everybody to a Zoom call. We'll answer your questions that you have submitted. Remember to check the member site. We have a number of new announcements in there. We've lowered the follow-up phone visit fee. And we have a self-scheduling option now. You certainly can call the clinic, but we have a little bit more constricted hours in the winter time, so it's pretty easy to self-schedule. We have that available on the member site and on the website as well. So also have a bunch of new videos in the lab section. Remember, I promised I was going to get videos out to help you better understand your labs. So I've been creating those. Those are in the lab section. They're also on the courses. I think I'm putting them on mainly the autoimmune course. Also making blog posts regarding them too. So I don't know if anything else is new in there. This is what the schedule looks like. So go ahead and click on that. You can click on the follow-up info form. That's the form that you have to fill out, so I know what we're going to be talking about at the call, and you can pay for the and schedule right there at the button too. It's on the home page of the member site and a couple other places, different pages on the member site, and again, it's on the website. So and it allows you to choose a Zoom call. So, and I would prefer that you choose the Zoom call option if we're going to go over labs. Just makes it easy because then I can share my screen with you, have the lab up, but I can circle things, just, I think it's better educational experience to go over those. Also remember all the courses are available for you. And we've only got well over 1,100 blog posts now, so been adding all my videos to the blog post too. First question, let's get going on this. As cancer cells die off, how does our body get rid of them? How are they expelled? So when cancer cells die, they die through a process of apoptosis. So apoptosis is normal programmed cell death. I have several blog posts about this. I think I call them apoptosis 101 and apoptosis 201, with some videos about it. So cancer cells can also die through abnormal ways, pathological cell death. Typically, that's how cancer cells die when you are exposed to chemotherapy. So chemotherapy is an oxidizing agent. It's a poison. And anytime a cell is poisoned, it dies through a pathological death, through a cell lysis. So the cell lyses, meaning it breaks apart, it bursts through an oxidative process. That's the danger of oxidizing agents that you're exposed to, chemicals and additives, colorings, flavorings, all these chemicals that are diet. They act as oxidizing agents, they act as poisons, and they cause cell lysis. So if you drank a poison, how does somebody die if they drink poison? You've seen it in spy movies. They drink a poison and they keel over and they're dead. Well, if you drink an oxidizing agent that's a very, very strong oxidizing agent, it causes immediate cell death, immediate cell lysis, and you could die quite rapidly. Well, that's what chemotherapy does. It causes cell lysis. Of course, it's not immediate cell death. It's going into the bloodstream, and you're hoping that it's taken up by cells that are more metabolically active, aka cancer cells. And it is. It is taken up by cells that are more metabolically active. That's how chemotherapy works. Unfortunately, your hair follicles are more metabolically active, and your immune system cells are more metabolically active. So you will damage your immune system. That's why they need to check it. Every time you go in for a chemotherapy visit, they need to do a CBC, see what your white blood cell count is before they can administer the chemotherapy. Because if it's too low, another dose of chemotherapy could kill the patient. So you got to make sure that your immune system has recovered enough since the last infusion in order to give you another infusion of a poison. So it makes it sound like it's a horrible thing, which it is in a way, but cancer cells will uptake that poison more readily than a healthy cell will. Therefore, it will kill cancer cells quicker than it will kill a healthy cell. Though if it lingers in the body, you will kill healthy cells as well. It does cause apoptosis sometimes, but more commonly it causes cell lysis, which is a pathological cell death. It's a necrosis of the cell, and that's a breaking apart of the cell. So in the case of cell lysis, the cell just explodes. It breaks apart, and all this cell exudate is all over the place. So those are called endotoxins. Endo means within, toxins. So it's not something from outside of the body, it's toxins from inside of the body, aka the cell components that have just exploded all over the extracellular space. And now the immune system has to deal with it. It can fire an immune response, which is going to be just an inflammatory type response, be a histamine response, other chemokine responses, which could actually cause more problems, more inflammatory cytokines to the area, not necessarily T cells that are going to kill cancer cells, but more inflammation and fluid that is going to actually hinder a T cell response to be able to kill cancer cells. It's a negative side of chemotherapy. So then that has to be carried into the lymph system and then through the bloodstream and basically detoxified. So it has to go through detoxification pathways. Now, the way a cell dies doing natural methods or using the Rife machine or using herbal therapies, those are stimulating an immune response to kill a cell through what's called a normal programmed cell death or apoptosis. And apoptosis is not a shattering of the cell. It's not a lysis of the cell. It's a recycling of the cell material. It goes through a whole process of what's called blebs. It's basically enfolding upon itself. It's basically the cell is enfolding and just kind of breaking into pieces, and then your body recycles that and reuses that. Therefore, when you do, Rife therapy or natural type therapies that are not oxidative therapies, now there are some natural therapies that are oxidative, but if you do natural type therapies that are not oxidative, they're immune stimulant type therapies, you don't get the Herxheimer type reactions. Technically, one of the ill feelings post chemotherapy is a Herxheimer reaction. The Herxheimer reaction is defined by when you have produced an excess amount of endotoxins that overwhelm your body and make you feel quite ill. You can feel a lot of malaise, a lot of fatigue. You just feel ill. You're overwhelming your liver detox pathways. So you're becoming toxic. So, chemotherapy makes you toxic because of the drug itself, but it's making you toxic because of the endotoxins that it's producing through cell lysis of both cancer cells and healthy cells. So how are cancer cells expelled? It depends on how they die. Hope that explained that. More details, you can look up apoptosis on our blog right there. Search apoptosis and you'll see a few videos on that. Is there a way to turn off the beeping noise emitted through the Rife machine or laptop? So the beeping noise is not coming from the laptop, but it is coming from the Rife machine and also from the bulb. Is there a way to eliminate it? No, you can put the machine under the bed. You could put something over it. You just don't want to, you want to make sure you're not overheating the machine. That's the only thing you have to be careful about. So you can cover it. We've had some patients put it in a drawer in the bedside stand, in a lower drawer, and it stops the sound. You could put a small pillow over it as long as you have air circulating underneath it. You don't want the machine to overheat is all, so make sure you're checking that. Now with the amplifier, jackhammer amplifier, you could put the bulb under the bed. So you're muffling the sound. That's really all you can do. The frequencies will make a noise, just as a byproduct of it that you can't get away from. Is hormone replacement therapy, BHRT. So BHRT stands for bioidentical hormone replacement therapy. Is this bad if you've had breast cancer? Well, bioidentical hormone replacement therapy, there is a non-bioidentical hormone replacement therapy. So if you just went to your medical doctor and asked for hormone replacement therapy, there's a lot of medications in the market that are not bioidentical hormones, and they can be are extremely dangerous. I'm very much against it. I don't even know if there's that many doctors that prescribe that anymore. It just increases the risk of cancers, of hormone-driven cancers, immensely. So I personally, I haven't heard of anybody taking it for a while, though I'm sure it's prescribed on a daily basis. Bioidentical hormone replacement therapy has kind of taken the place of that. It's said to be more natural, and it is. It's a much healthier substitute for the medication hormone replacement therapy. But the negative is that you still have to really be careful if you have a hormone-driven cancer. Even if you had breast cancer that was triple negative, I still wouldn't be an advocate of using hormone replacement therapy, bioidentical even. You still have to be really careful. The thing to do is to run a Dutch test, and you'd have to keep an eye on that on a very regular basis if you're going to do that. Now, there's times where using bioidenticals can be beneficial. Using some progesterone or using some testosterone. You'd have to be more careful with the esterones because of even if you have triple negative breast cancer, because it is the bad estrogen. You're going to be, if you're taking an estrogen, the chance that it's going to, or you're only one step away of it breaking down into 4-hydroxyestrone, which is the more dangerous estrogen. You'd also want to look at your COMT genes as well, because if you have defects on your COMT genes, then I'm not a fan of doing a bioidentical hormone replacement therapy at all, because you do increase your risk for breast cancer, even if you haven't had a diagnosis. So it's something you want to be careful with. I know there's a lot of doctors, especially out on the West Coast, that are really big into doing bioidentical hormones, and it's very common to keep a person feeling younger in many ways. And I'm not saying it doesn't have benefits, but it also has risks. Do oncologists really believe that their care has to start immediately? Well, that's kind of a loaded question. I think the truth is that different oncologists believe different things, and it's hard to make a gross and have a gross answer to that because everybody's different. I do believe there's a lot of oncologists that really think that you need to start their care immediately, and your chance of recovery and overcoming your illness increases the faster that you can, the earlier that you can diagnose a cancer and the faster you can start care. But I do believe that the reason why they believe that is because they've been brainwashed by the pharmaceutical industry. There's not a lot of evidence that supports that. Now, I would agree with starting care earlier if you have certain types of cancer. So if you have a cancer that's growing quite rapidly, then starting a more invasive care protocol if you is probably in that patient's best interest. If you're going to start chemotherapy, if you've made the decision to do chemotherapy or radiation therapy or surgery, and then you're just putting it off because of other reasons, that might not be a good idea at all. If you're going to go through it, you want to go through it in the healthiest state you possibly can. However, cancer's become a huge economic, bust for oncologists. It's only oncologists that make money off their prescriptions. All doctors make money off vaccinations, but oncologists make money off of their prescriptions. So if they prescribe chemotherapy, their income goes up. Also, the cancer industry is really just a financial industry. If I was an oncologist at the University of Minnesota and I was telling people to do herbs and to hold off on their chemotherapy, I would A, be fired, and B, be written up in front of the board, probably C, have my license suspended, at the very least. So they are under a lot of pressure. I've had doctors tell me that they're in the golden handcuffs. They can't get out of it. They don't make their own decisions. They are controlled by the hospitals and the big oncology clinics. So if I worked for Minnesota Oncology, guess what? It's run by masters educated hospital PhDs and such that aren't medical doctors at all. They're just trained how to make the most money for their industry. Interesting on this note, I had a patient, this is about 10, 12 years ago. She had metastatic cancer. I can't remember what her original cancer was off the top of my head, but she had metastasis and she was in the hospital and she called me. I gave her my cell phone because she was, going through a lot of struggle. She called me and said, I'm in the hospital right now and I am so mad. She goes, why? She goes, the oncologist was just in here and he said, if I don't start radiation immediately, I'll be dead in 2 weeks. I said, what? She goes, it just makes me so mad. How can they say that? How can they say that? Understand, this woman was very much against doing any radiation. She was so upset. And I talked her through it. And we just tried to reason together, like I always do. It's like you know that you're under a lot of pressure, but it doesn't necessarily mean that their recommendation is bad. Just because we maybe disagree with their bedside manner, we disagree with their high pressure tactics, doesn't necessarily mean that their recommendation is wrong. Well, it all came down to she was having difficulty walking. She had metastasis to the spine. She could, she had pain that was so bad. She finally agreed to the radiation. So she called the nurse in and she said, okay, I want to talk to the radiation oncologist. He came in and again said, if we don't start radiation immediately, you're going to be dead in 2 weeks. So she said, okay, I talked to my other doctor, B, and I agreed, I'm willing to start the radiation. He said, great, I'm going to have the nurse come in and get you scheduled. Comes in and gets you scheduled. The first opening they had was in 3 weeks. So they scheduled her in 3 weeks. She called me back. I have never heard somebody so absolutely livid on the phone, and rightfully so. I'm going to be dead in 2 weeks if I don't start radiation immediately, said the oncologist. I finally agree to it, and their first opening is in 3 weeks, and he's okay with that? That doesn't even make any sense. Well, this is the nonsensical high pressure tactics that they use. Matter of fact, when I was looking for some pictures for this post, there's seminars out there for oncologists to learn how to get people to agree with their care. I mean, I remember years ago when chiropractors were just lambasted for using high pressure techniques, and it was just horrible on what they were doing. They couldn't even hold a candle to what oncologists do today. Horrible high pressure techniques. And maybe it's because they're pressured by the owners of the oncology clinics. the oncology centers, the hospitals, I don't know, but it's awful. And one of the main things that we have always said is you always have more time than they lead on. Always make sure that you take everything to prayer, that you slow down. There's always a benefit to talking to multiple people and getting second opinions. I can't tell you how many people, my own sister was told that if she didn't do chemotherapy, she was going to be dead. In that many words by somebody at Minnesota Oncology. She went down to Mayo for a second opinion, and they said, well, we wouldn't even do chemotherapy in your case, and they offered her immunotherapy, which she did one session. She didn't do well on it, but I do think it really helped her. She's still alive today doing natural methods. I just think that it's just sad. It's just downright sad. So yes, I do think there's some oncologists that are brainwashed into thinking that they have, if they don't start care immediately. But I also think that they don't think any other care is viable. I think they think that they're maybe a little bit higher than God on the scale of knowledge, and nobody else knows a thing. It just is what it is. So I think there's wisdom in a multitude of counselors. So there's nothing wrong with getting their opinion. There's nothing wrong with starting their care, but don't do anything based upon pressure, and certainly don't make decisions based upon fear. Please discuss how we women and men can receive a safe and proper biopsy that will not leave cancer cells in our bodies to later start seeding other tumors. Well, that brings us to the question of, do biopsies cause metastasis? An honest oncologist will say, yes, they can. Matter of fact, I just pulled up this article right here that does state, this is from an August 2017 article in this journal, that does state that core needle biopsies of breast cancer is associated with a higher rate of distant metastasis 5 to 15 years after diagnosis. So what, I mean, think of a biopsy. You know, if you're going to go in with a core needle biopsy to a breast cancer, they have to go in with a needle, and then they're pulling that out. And when they pull it through the other tissue, some cells are being discharged. So you do risk the increased chance of metastasis with a biopsy. The problem is that doesn't mean that you shouldn't get a biopsy. So the truth is that the closer the tumor, if it's a breast tumor, the closer it is to the surface, your chance of causing a metastasis from the biopsy goes way down, because you're actually pulling the needle through less tissue. If it's a deeper tumor, your chance will go up, because you're pulling the needle through more tissue, and you'll be letting more cells go outside of the tissue. But the truth is that almost every cancer has given off circulating tumor cells long before the biopsy was even thought to be needed. So I'm not against doing biopsies. It's the only way we can get the pathology of the cell type anyhow. So you can't legally get a diagnosis of cancer without a biopsy. So biopsies are a necessary evil, especially if you are going to do any care through your oncologist. They're a necessary evil to find out the exact pathology that we're dealing with also. However, we've had patients, come to us that say, I feel like I have, breast cancer. My sister had breast cancer. My mom had breast cancer. This is growing. They want to do a biopsy, and I'm not going to do it. Could you just treat me as if I have breast cancer? Well, yes, we can, because we don't treat the cancer anyhow. But in order to get a proper diagnosis, you need to get a biopsy. Now, it doesn't mean you need a proper diagnosis to treat it from an alternative perspective. But if you're going to do anything in the medical field, if you're going to go and, consider any of their care, they're going to absolutely require, a pathology report obtained through a biopsy. So you're going to have to go through that necessary eval. So, yeah, there isn't a safe and proper biopsy. Let's take that back. I think most biopsies are pretty safe. You do increase the risk of metastasis, but you increase the risk of metastasis by having cancer. So it's pretty difficult to ascertain whether the metastasis was because of the biopsy or was it just because that you have circulating tumor cells. So yeah, it's a tough call. There isn't any other way to truly diagnose cancer without a biopsy. I have just been diagnosed with grade 1 breast cancer. Can sugar in your body promote cancer, or is it just estrogen driven? So remember, estrogen doesn't drive the cancer, even though I think I just used that terminology in another question. With estrogen receptor positive breast cancers or other cancers, any estrogen receptor positive cancer, estrogen isn't driving the cancer, but that 16-hydroxyestrone is attaching to the estrogen beta receptors, and that is blocking apoptosis. That's what that means. So when you have a hormone positive cancer, that means a hormone is attaching to a receptor on the cell membrane of the cancer cell, which is an apoptotic receptor. So back to what is apoptosis. It's the normal breakdown of a cell. You want a cancer cell to go through apoptosis. But when it's being blocked, then it doesn't die and it continues to replicate. That's a bad thing. So there's multiple pathways of apoptosis. There's an intrinsic pathway that's generated by the interior part of the cell, and there's an extrinsic pathway of apoptosis that's generated by these receptors. So when estrogen is blocking that receptor, then it's blocking the normal programmed death of that cell, and it keeps the cell alive, and therefore the cell can continue to replicate and the cancer can continue to grow. So it's not really driving the cancer, but it's blocking apoptosis. So in that sense, I guess it is driving the cancer. But the cancer has to be fueled from something. So that's a totally different thing. It's either being fueled by sugar, glucose, or it's being fueled by iron, or it's being fueled by amino acids. And once you cut off the fuel source, it will really help the cancer not to be able to continue to replicate. But cancer's smart, so cells are smart. They're just trying to stay alive and trying to replicate, though the DNA has damaged them and they're replicating way too quickly. That's what cancer is. They will look for a new fuel source. So that's why you might need to be tweaking and changing your diet throughout your care. So yes, sugar in your body can promote cancer by it being a fuel source. Estrogen, yes, can promote cancer by it blocking the receptors on the cell membranes of the cancer cells, therefore blocking the extrinsic pathway of apoptosis. I submitted a question last week regarding the metastatic prostate cancer with my PSA being 0.1 and androgen deprivation drugs being used. I do still have my prostate and did check out your blog post on this. You already have me on Tivigo. So Tivigo is a green tea extract. That's a real clean green tea extract. What does that do? It helps decrease the interleukin-6 levels, which is really important for everybody, but it's even more important if you're on Lupron for prostate cancer, Prostaclear for other things for the prostate cancer, mushrooms, quercetin, turmeric and quercetin both help that interleukin-6 as well, Clear Amino Pack. What else do I need from that blog post? You need andrographis. So this Immunomod A is a great source of andrographis. 4 of these a day will give you 250 milligrams of andrographis, and I highly suggest, just like as much as you can do with your other supplements, is to break it into doses. So if you could break it into 4, take 1 in the morning when you wake up, 1 at noontime, 1 at 4 o'clock, and 1 before you go to bed, that'd even be the best. So a lot of studies on hydrographis with prolonging the benefits of androgen deprivation therapy. Highly recommend that. This also has just some other anti-inflammatories, and it's a really good thing to calm the inflammation. And this is like a perfect supplement for anybody doing that. All right, that was the questions we had come in. If anybody else has any questions, we can wait a few minutes here. What version of the Rife program is on the laptop you sent us? Oh boy. You can see if you look up, just open up your Rife program and go to look at about. I think I put on. Oh, I think the one I just sent you, I put 6.0 on. That's what I did. So I did put 6.0. I didn't put 6.4 on. I just thought, well, let's just wait until 7.0 comes out for you, because it was it wasn't a real beefy computer. So it was a refurbished one that I had. It probably might work for 2 more years. But I just thought it'd be better if we just put 6.0 on. 6.0 and 6.4 don't function any different as far as, and understand, there's no difference in power on your program for 6.0, 6.4, 7.0 when it comes out. There's no difference in power. It's just there's some functional things with 6.4 that can be better. A lot of people that have 6.4 don't like it because it's a couple extra steps to get to your program. So I thought, well, we'll just keep it simple for you, put 6.0 back. Dr. Christy Funk says to take soy because it goes in the receptor instead of the body generating estrogen. I believe you're not in favor of soy. Please explain this. So the soy that she's talking about is fermented soy. So fermented soy does exactly what she just said. So if you have fermented soy, it actually dislodges the bad estrogen. It acts like a crowbar. It dislodges the bad estrogen out of that receptor. So it can be extremely beneficial. So it's a great thing to use. Fermented soy, as far as a product goes, would be in the Highland 951. That's fermented soy. That's the only product on the market that has fermented soy. You could take fermented soy in like miso, in food products. You do have to develop a taste for it. It's different Japanese cuisine, but it's you know, you'd have to get true, good fermented soy, and then you'd want to make sure that it's non-GMO. So, because that would be a problem too. So, product-wise, it's the Highland 951. That's a fermented soy that dislodges the bad estrogens out of the estrogen receptors. Any other soy it works exact opposite. So any other soy, if it's not fermented, actually can promote 16 hydroxyesterone production, which could cause problems. I just received my new Rife. What version is mine? So it's really easy to know what version is yours. If you just hit open home or open program on your laptop, and it opens up, and if you can see your name immediately, then you're in version 6. If you have to go to documents and then open up TrueRife frequencies in order to see your name, then you're in version 6.4. It's also really easy to see what version you're in. Let me just pull up my computer real quick. If you pull up your TrueRife program, on the top bar, you'll see help. If you click on help, it'll pull down and you'll see what's a little tab called about. If you click on about, it'll tell you what version you're running. So that's how you know what version you're running. All of you running 6.0, when you open up your Rife and you open up the open home button or the open program button, and you see AA, your name right on top, you're running 6.0. If I see all the programs, but I don't see my name, and you have to go to documents and then TrueRife frequencies in order to get to AA, your name, then you're running 6.4. That's the hassle of 6.4. So anybody that I've upgraded to 6.4, anybody that's received a brand new computer is running 6.4. So the person who just asked me, I think you're running 6.4, Debbie. You're running 6.4. You have a new computer. So if you have a new TrueRife computer, you're running 6.4. If you have an older laptop, a HP laptop, some of you have asked me to upgrade that to 6.4, which I did. It does take more RAM to do that, so I've hesitated to do that now, and I just make sure that their personal program is 6.4 ready. Any idea why cryoablation isn't recommended in standard of care instead of lumpectomy or especially mastectomy? That's a really good question. To be really honest, and I don't mean to be cynical, it probably has to do with money. Most things are not going to be recommended that they can't make money off of. So, with that, cryoablation clinics charge for it. Why can't just the oncologist charge for it? I don't know. It's just most of the decisions that are made from a medical perspective have to do with finances. Remember, these hospitals are not run by doctors that are constantly reading journals. They're run by, Harvard graduated people that all they're into is making more money. So it has nothing to do with patient care. It has everything to do with covering their behind from malpractice insurance and pleasing the pharmaceutical industry who they're in bed with. And I don't say that in a cynical way. It's just the truth. So it just is. I have just begun taking 10,000 IUs of vitamin D daily. Last I had it checked about 2 months ago, my level was 55. I live in Iowa and I'm getting virtually no sunshine. How often should I get my level checked? Well, if your vitamin D level is 55, that is certainly not high. So taking 10,000 a day, is that dangerous? Not if your vitamin D level is 55. If your vitamin D level was 155 and you're taking 10,000 a day, I'd be the first to tell you to decrease your dosage. There's nothing wrong with 155 vitamin D level. Still don't think there's any danger in that, but you certainly don't need to be taking 10,000. So when should you get your vitamin D level checked again? If 2 months ago it was 55 and you just started taking 10,000, I would say a couple months. However, I would say you probably should be getting blood work more often than that. So if they're going to do blood work to test CBC levels and complete metabolic panel, why not ask for a vitamin D level? I mean, literally, it's a $3 add-on to that test. So there, every time you get blood work, just ask for a vitamin D level. Can DIM be used instead of soy? Sure. DIM can be used instead of soy. It's go to the blog again and search aromatase inhibitors, and you'll see different things that you can be used in place of soy. And I think what you're talking about is fermented soy. So you wouldn't use soy again. So you'd use fermented soy. But fermented soy, again, doesn't act as an aromatase inhibitor. It acts as a dislodger. Here would be the blog post that you look for. Just search aromatase on the blog. It acts as a dislodger of bad estrogens. So aromatase inhibitors would be DIM and I3D, I3C, and um, um, it's slipping my mind right now, but you can look up the different aromatase inhibitors on. Tony wanted to know if radiation treatment can cause hard bumps on the skin, like keloids or something. They haven't changed in color or size, so the oncologist isn't worried, but they aren't sure what they are. Yes, it can. So, indole 3 carbonyl. Thank you. Yes, it can. So one of the dangers of radiation therapy is you could end up with skin cancer. So um, I would use some essential oils on that. Make sure if it's a hot oil that you're adding a carrier oil to it. Um, adding some different creams to that. Most oncologists post-radiation will recommend some post-radiation cream that's anti-inflammatory. Many times steroid cream and things is recommended. But I would definitely use some essential oils and things on it. I'm getting my implant surgery on January 8th. How long do I wait to send in a cheek swab? I would say right after your surgery. I think I should check to see if any changes in that programmatically. Yeah, just give a couple days after your surgery. That would be perfect. All right, I think we'll say goodbye. We'll be back next Wednesday. Make sure to get your questions in and remember about the self-scheduling option. If you have to want to talk to me about anything personally, just self-schedule. And we'll talk to you guys next week. Bye-bye.